Thank you very much, Jean-Louis, for the introduction. Yeah, mean systemic filling pressures. This is possible conflict of interest, nothing related to this presentation at the moment. Well, let's first ask ourselves, what is mean systemic filling pressure? Basically, here. So mean systemic filling pressure is the pressure in the system brought about by your stress volume. As you know, the total amount of blood volume is divided into a part that contributes to the return of blood to the heart, the stress volume, and there's a part not related to or contributing to the return of blood to the heart, and that's the unstressed volume. Now, this stress volume, as you can see in this cartoon, this determines a pressure that will generate a pressure for the return of blood to the heart. The resistance to this pressure is basically the central venous pressure, because if the central venous pressure rises and the mean systemic filling pressure does not rise, you will have a decrease in venous return and cardiac output will decrease. Sheldon Magre will tell you everything you want to know about central venous pressure. Now, how to measure this stress volume? So if the stress volume is very important, then how to measure it? Well, that's a little bit difficult. I don't think, maybe Sheldon will not go into this, but he's probably the only one who did this in an intact human being. Already quite some years ago, 1998, what he did is he drained the right atrium in patients with circulatory arrest. And as you can appreciate this slide, if you stop this pump, the pressures in the system will equilibrate, and so they will equilibrate to this pressure. And so that's what Sheldon did in this experiment. In these operations, they had to have a removal of all the blood in the surgery, and they did it when they stopped the circulation. So it's not a real physiological model like we sit here, because they were cold, 19 degrees, and of course deeply sedated. On a mechanical ventilator, they stopped the heart, drained the right atrium. And so, as you can appreciate the previous slide, everything that comes out of a circulation at a stopped beating heart is your stress volume, because the unstressed volume cannot come out of your system at this point. So how much of your circulating blood volume is contributing to venous return in a model like this? It's about 30%. And basically that's the same in animals, where you can do these studies, of course, much more easy. This is more or less similar in animals. So about a third of our circulating volume is contributing to venous return, and 2/3 is inactive in a way that it's not contributing to venous return, but you could recruit part of your unstressed volume to make it stress volume, and that's adaptation. Once you start running out of the room because there is a danger in the audience or whatever, you will immediately start to recruit your unstressed volume into stress volume in order to increase your cardiac output. And so the mean systemic filling pressure and the central venous pressure are very important pressures in your system. And the mean systemic filling pressure is a determinant of venous return, and it's brought about by the amount of volume in your venous system, and of course the vascular tone of your venous system, or the capacitance of your venous system. And you could say the resistance to venous return is central venous pressure. And so if you have this cartoon and you have these pressures and the importance, and you appreciate the importance of these pressures, you could say, well, then we have pillars of circulatory failure, because then if this is your circulation, you only have 3 pillars for your circulation to fail. And the one is, if your pump is not working, you have a problem, absolutely. If your pipes are not working and you have massive vasodilatation, you will have low blood pressure, and you might and probably have dilatation of your venous system as well. And so the capacitance increases, the mean systemic filling pressure decreases, and the venous return to your heart decreases. That's basically what happens in an endotoxic model or septic model of septic shock. When you introduce the sepsis, you get venodilation and a decrease in return of blood to the heart. And the next and very important one is a volume problem. Now, there's a lot of misunderstanding about hypovolemia. I asked in the PG course, if you inject me now with endotoxin, am I hypovolemic? And many said, yes, at that point you're hypovolemic. No, of course not. I'm not hypovolemic. There is no problem with my volume at this moment. What happens if you inject me now with endotoxin is that I will have an immediate increase in my unstressed volume. But the total circulating blood volume that I have in my system is completely normal because I'm not dehydrated. I drank enough coffee and water today to have a normal circulating volume. So the volume problem in many cases is a problem of unstressed or of stress volume. And so you could turn unstressed volume into stress volume, for instance, by giving a vasopressor or by adding volume to the system and increasing your stress volume. And so this pressure for venous return, the difference between this pressure brought about by your stress volume and your CVP, that's a very important pressure. Because if your fluid resuscitation doesn't result in an increase in this pressure, you will have no effect of your fluid administration. So if your CVP rises when you give fluids, and your mean systemic filling pressure doesn't rise more than the rise in CVP, there will be no effect. And so it's an incredibly important pressure. Now the question is how to measure it. That's somewhat more difficult. If you take it to the basics, the mean systemic filling pressure will be there when you stop the flow, like Sheldon Magner did in the experiment. Well, that's something we don't frequently do in our patients. You can do it in a patient who is sedated on a ventilator, deeply sedated, and who is completely pacemaker dependent. When you test your pacemaker, for instance, following bypass surgery or heart transplantation, the patient is sedated, you want to level your pacemaker and see at what microvoltage you need to have the signal. You turn the pacemaker down, the heart stops. If you then look at your central venous pressure, you will see an increase by definition. Otherwise, the blood would be flowing out of your heart instead of back to your heart. That's what they did in this example. Central venous pressure is 6 millimeters of mercury. You decrease the activity of the pacemaker or turn it off. You will have a systole at that point. The CVP rises immediately, as you can see here, and levels off at 10. And so the circulation of this patient operates at a pressure difference of 10 minus 6. That's 4. And so our circulation, and probably it's not very different in our situation here, operates at a very small pressure difference. We don't need a lot of pressure to have venous return to the heart. Now that's very impractical, and possibly no IRB will help you to do studies like this in patients. But there are other ways, basically 3. This is probably the most published one. This is calculating the venous return curve from inspiratory holds. What do? If you do an inspiratory hold, you will change the venous return to the heart. And so you will have a change in cardiac output. If you do this at different pressures, you will have different points at the same venous return curve. If you do a linear regression of these points, then the point where you reach the x-axis is the point where the flow would be 0 and you would have your mean systemic filling pressure. And so this is the co-chair of the session, and Xavier Monet did a lot of work on this using this method. And this is maybe the most clean method because it's not influenced by a lot of other problematic stuff. Jacinta Maas from Leiden did her PhD on this, and she evaluated the 3 methods. If you're interested, then please read this paper where she evaluated the relationship between the 3 methods. So this is one. The other one is really simple, but not very easy to replicate, to be honest. If you stop the flow in an arm immediately, so immediately compress the arm, and you have an arterial catheter, then the arterial pressure that you're measuring in the arm will equilibrate with your venous pressure in the arm. And that is a function of mean systemic filling pressure because the venous pressure in your arm is bigger than the central venous pressure, otherwise you would have no blood supply to your arm. And so as you can see in this example, if you stop, immediately stop, so not slowly increase a blood pressure cup, but you have to do it very quickly. If you immediately stop the flow in the arm, you see that the arterial pressure equilibrates with the venous pressure. And so after about 20 seconds of occlusion, you could reach the mean systemic filling pressure. And finally, and that's the most simple method, but a little bit complicated because there could be some mathematical coupling in it, Jeff Parkin in the Journal of Clinical Monitoring and Computing said, well, if you look at the Guyton representation of the circulation, it looks like an electronic circuit. So maybe we can estimate the mean systemic filling pressure viewing the circulation as an electronic circuit. And he came up with this analog of the mean systemic filling pressure in a calculated model. The algorithm is published, so basically you could incorporate it in every monitor that you have in your own system. You measure or you calculate the mean systemic analog from right atrial pressure, mean arterial pressure, and cardiac output. And here you see the mathematical coupling of cardiac output in a model like this. And so you could do this. Jacinta studied the relationship between the three, and although this underestimates mean systemic pressure a little bit, the relationship between the other methods is very good. So this could be a very practical model of how to do it. Now, what's the importance to think about mean systemic filling pressure in clinical practice? Why would I, if I can't measure it, if you don't have the algorithm, why would should I be interested in thinking in mean systemic filling pressure? Well, if this is a cartoon of your circulation and this is the entry pressure of your microcirculation, then remember that the mean systemic filling pressure that you either measure with the inspiratory hold method or that you calculate with the algorithm is close to your post-capillary pressure, the closest pressure to your post-capillary pressure. So if your mean systemic filling pressure is high, the exit pressure of your microcirculation is high. And I won't go into the effect of hypotension and vasodilation on the entry pressure of your microcirculation, but high mean systemic filling pressures don't seem to be a very good point if you look at the perfusion of your microcirculation. So the calculation that you do at least gives you an estimate of which pressure the microcirculation is facing, as this is this pressure difference, here CVP and here mean systemic filling pressure is, of course, the driving pressure. Now, together with David Berlin, basically he wrote the stuff, to be honest. David wrote a review, Understanding the Disease, on what is venous return. And venous return, and this is adapted from the model that Sheldon Magder introduced a long time ago, where he used the bathtub. And the interesting thing in thinking in this way of venous return is two things. First, the only thing that you try to accomplish with a fluid resuscitation is increasing your stress volume, as I said before. And the other thing is, what's the importance of blood pressure on venous return? Like Sheldon used in his bathtub, if you pull the plug from a bathtub and you open up the tap, you won't get more water out of your bathtub. Cardiac output is not important in this huge amount of unstressed volume to have a return of blood to the heart. And that's what we, let's say, schematized here as well. Cardiac output is not important for venous return. Is that true? Is there any evidence? Yes, there is. It's already old evidence, 1965, and this is Cohn, who did a study on the effect of norepinephrine. That's combined effect of alpha and beta, and angiotensin. And angiotensin is more or less a very pure arterial vasoconstrictor. And as you can appreciate here, angiotensin increases blood pressure to the same amount as norepinephrine, but angiotensin has no effect on cardiac output, whereas norepinephrine has a very significant effect on cardiac output, a 40% increase, whereas this is hardly any significant increase, less than 20%. And so that makes sense. If you increase norepinephrine, you will increase venous return, and that's why you have an increase in cardiac output. That's been shown by the group from Chauvet and Jean-Louis already in early septic shock. If you give norepinephrine to increase blood pressure, your global end diastolic volume will increase and cardiac output will increase as well. What is it the other way around? Does it hold in patients, or in this case, healthy volunteers? If you do it the other way around, if you decrease the stress volume, will the pressure for venous return change similarly? This is a study from the Mayo Clinic, from Blair Johnson. And what they did is they subjected healthy volunteers to lower body negative pressure. And so that decreases the venous return by pooling the blood in the lower side of the body. And after that, and after recovery, they withdrew 1 liter of blood in 3 steps of 330 mLs. And so this is, let's say, this is mimicked hypovolemia, and this is true hypovolemia, 1 liter of blood out of a healthy volunteer. Now, if you then, and that's what Elizabeth Dirks, a fellow of us in Rotterdam, did, when you then calculate the pressure for venous return in these healthy volunteers, and remember you're going that way, you're decreasing the pressure for venous return by either lower body negative pressure, the blue ones, or by blood loss, the red ones, and you see a perfect relationship between the pressure for venous return and the cardiac output, as it should be. There should be a relationship here. If you plot CVP here, there is no relationship at all, and Sheldon will exactly explain why there should not be a relationship as well. But there should be a relationship between the pressure for venous return and cardiac output, and you'll find it. Now, we still have problems adequately measuring these pressures, especially, of course, in healthy volunteers, but the relationship is good and very significant, as you would expect from physiology. So that's healthy volunteers. We went to patients, and Luc Meijs from Eindhoven did a study in cardiac surgery patients, and he's finishing his study in septic patients, and we divided the group into CABG, so bypass grafting and valve replacement, and we looked at the effect of passive leg raising, and we also looked at the different aspects of passive leg raising, but not important for this presentation. And if you do a full passive leg raising, so thorax down and legs up, you will have responders, patients that increase their cardiac output, and you will have non-responders that won't increase their cardiac output. Why do the non-responders not increase their cardiac output? Because there is no change in the pressure for venous return, whether you're following a patient following bypass grafting or whether you're a patient following a valve replacement. If your pressure for venous return doesn't go up with a passive leg raising procedure, you will have no change in cardiac output. When does cardiac output change? If you have a significant increase in the pressure for venous return by putting the thorax down and the legs up. And that's very interesting. You have this problem with this mathematical model where the change in cardiac output is incorporated in the calculation of your mean systemic pressure analog from Jeff Parkin, and so there is mathematical coupling. Well, Xavier Monet just submitted this paper to Critical Care, and I'm very grateful that I can use his slide because it's unpublished work. And they used the calculation of mean systemic filling pressure using the inspiratory hold, so a completely independent method. And they looked at passive leg raising and fluid resuscitation as well, like we did using the algorithm. And they found exactly the same. This is in shock, but they found exactly the same. So this is baseline fluid responders. Why do they respond? Because the mean systemic filling pressure minus CVP, the pressure for venous return, increased. And this is the same after fluid expansion, and in the non-responders there is no change. So this concept of mean systemic filling pressure and your resistance to venous return being CVP, and the difference between the two being the driving pressure, helps you to greatly understand what's happening in your patient. So, in conclusion, mean systemic filling pressure is the pressure in the venous system at zero flow, and it's around 6, 7, as you saw in the pacemaker example. The right atrial pressure is a resistance to venous return, and the driving pressure for venous return is the mean systemic filling pressure minus your right atrial pressure, and thus represents one of the most important pressures in your system. Different methods are available to estimate the mean systemic filling pressure. The most easiest one, the algorithm, and the somewhat more complicated one, the inspiratory hold. And I think the principle of this pressure for venous return and the resistance to venous return helps to understand and maybe choose a fluid resuscitation greatly. Thank you very much.